To those in the United States, Kalispera to those in Greece. We are going to, someone is asking whether it is allowed for them to record the webinar themselves. We don't have any objection, do we? No, we will be recording it ourselves and posting it. But if you wish to record it, that's fine. So welcome. This is our second symposium that we're having this year. Very excited. Our first symposium with the University of West Attica Department of Public Health Policy and the Rutgers School of Public Health. The topic is migration and COVID-19. Next slide. So my name is Marian Passananti. I'm the Associate Dean for Educational Program Development at the Rutgers School of Public Health, and I'm a professor in the Department of Biostatistics and Epidemiology. And I am joined by Ohema Bohema, who is the Coordinator of Global Programs and Practice at the Rutgers School of Public Health. Ohema gets all the credit for coordinating this activity, so thank you very much. And we are the Office of Global Programs at the Rutgers School of Public Health. Next slide. So this is just a little housekeeping. We're going to ask people during the presentations to please keep your computers muted and videos off. Once the presenters do their presentations, we will have a time for question and answer. During that time, you are welcome to put your cameras and audio on as well. Please put your questions into the Zoom chat feature if you have questions during the presentation, and you indicate if there is for a specific person who's presenting, so we'll have a record of those, and you'll also be able to unmute yourselves and ask questions. So we have 4 very distinguished panelists today. Each of them will be presenting a 15-minute presentation. And then after all the 4 presentations are completed, we will do a Q&A session. And we are recording the webinar. And if you have any technical issues, please contact Ohema. That is her email address, and she will assist you. Next slide. So these are the pictures of our 4 distinguished speakers today. And at this point, I am going to hand this over to my colleague at University of West Attica, George Kouliarakis, who will introduce our first presenter. George, you need to unmute.
Sorry, thank you. Thank you, Dr. Passanante. My name is George Kouliarakis. I am Associate Professor at the Department of Public Health Policy and also instead of head in the department. And it's a great pleasure to welcome you all to have a good morning in the US. Καλό απόγευμα, καλησπέρα στην Ελλάδα. Without any delay, it's a great pleasure to introduce you the first speaker, Dr. Elizabeth Johannidi. Elizabeth was an ex-senior researcher at the Department of Sociology of the National School of Public Health. For those not familiar, the National School of Public Health is an historical school and now have been merged to with the University of West Attica and is the Department of Public Health Policy. Ellie, the floor is yours.
Thank you very much. Thank you all for this great opportunity to contact people in a place I love, New York, where I did my studies 40 years ago. I'm really moved to be at this moment to be able to address the students of Rutgers and our students in University of West Attica. What I'm going to present here is, this is not a research financed by anybody, it's an initiative. If you put next slide, it is these universities, it is an initiative by the University of Ghent in Belgium. And these universities that we were in the past partners of a COST program, we got together and we decided, next slide, to to study, the Part Together study is to reach out to the refugees and migrants at an international level and see the impact of COVID. What we try to do is not to see how many of them were infected, but the measures that we took, what is the impact of these measures on this population? At this moment, I want to tell everyone that this is the first raw data that came in. There are no correlations, nothing. I'm going to speak about 9,000 participants, the answers they gave. And now that we completed it by the end of middle of November, we had 28,800 more people. It is the questionnaire is translated into 37 languages, and now over 150 countries took part in this survey. It is an online survey. The way we did it, participants had to be over 16. And the way we did it is we tried to contact in our countries NGOs, organizations that work with migrants, and to pass the questionnaire in through their phones, any kind of way to complete, laptops, whatever, to complete it. The problem was that we didn't put a filter anywhere between migrants and refugees, and anybody could complete it. So it is a little, the sample is a little biased toward migrants of first generation, of course, in many countries. And when we started the initiative, the idea was to try to reach out to those at a shaky situation, like non-documented people and asylum seekers. Next slide. As I said, till September, we had 8,000 participants. You can see the gender. Next slide. We had, as you see, this is what I'm talking about, the sample is biased. Most of them live in house and apartment because a lot of them were migrants living in a country, and many of them were refugees in many countries that had already their documents and they were given a house and apartment. I'm interested always in asylum centers and refugee camps. And the people on the street that I put red, when we see 1.40 in this sample, we are talking about 103 persons, right? It is not a small number. Next slide. The residents, some of them were, you see the citizens, these are the migrants that they live in a country, some with permanent documents. Again, the red, the 8.4% is the non-documents without legal. This is the group personally I'm interested, because in Greece we have a lot of these people, and with temporary documents you can see 33%. Next slide. The situation, you see some of them were students, some were working, some were working normally, they had a job. And of course, the other is a big number because these are people who are not supposed to work. I mean, they cannot work. They don't have the documents and things like that. So at this time, as I said, I don't have any other data to see who are these, what is the meaning of this other. Next slide. Now, if you see the symptoms, 8% think they had some corona symptoms. This is according to their estimation. Next slide. Positive, there were 3%. Most of them were not. The no answer is a problem again, because in this questionnaire, they could leave at any time. I mean, they could skip questions. In the end, we realized that that was a bad idea because they left a lot of answers were not answered, and now we try to clean the data. And now that we have the whole sample, we try to clean the data and put out those questionnaires that were partly or a little bit, I mean, they answered partly. Next slide. The precautions. If you see the precautions, for example, washing hands all the time and sometimes, it's a big number. The next one. Keeping physical distance, yes, all the time and sometimes. Next slide. Covering nose and mouth in public. You see in big numbers, it appears here that they realize what they are supposed to do, and they say they do it all the time or sometimes. Next slide. To avoid public transport, they say yes sometimes, and of course, in the situation, I'm not able, the 9.88% is the number of people who cannot do that. Next slide. Now, where they get information, I found it interesting that from the country they live in, these are the people who can speak the language, right? Can understand the language. That's why for me in Greece, it's surprising because here the information, our refugees, they don't understand Greek. And probably the second answer from the country I was born, 38.75%, are those who get information from another country. And of course, NGOs, social media. Look at the social media. It's the big numbers. Okay, next slide. Now, if the family, if they contact a doctor, yes, most of them, they say yes. That means they have the ability. Next slide. This is again the answer I'm interested in. Fear of this deportation. We're going to healthcare, 10% with this sample we have. They are afraid. Next slide. The housing situation now, since the corona crisis, if they have difficulties in the housing situation, it is worse than before. You see the 27%, it's a considerable percentage with housing. The next one, accessing work, you see 43% they cannot work. The next one, feeling of safety, 56% they feel unsafe. The next one, food worse, 24%, they are not able to get food. Next one, financial means again 41%, worse than before. The next, the health situation at 20%, and they say it's worse than before. Next one, relationship, if they have difficult relationship with the children, as most of them non-applicable, they don't have children, they are young people, that's why it's not applicable. Next one. You see here, because if they try to access legal information procedures with the corona and the lockdowns and things, they have problems. 15% here, they say they are canceling asylum tribunals. Next one. And the changing meetings with immigration lawyers, 17%. The next one. Those who are waiting for a resident status, again, they have a problem. Next one. Difficulty accessing legal information and support, yes, it's a 26%, those in need. Next slide. If they can connect with people, with the family in this country, it is worse because even they can lose their family, 23%. The next one is in another country. They cannot travel, probably those who are able to. The next one, with friends, you see worse than before, they cannot meet with their friends, 48%. Next one. In another country, worse than before, 26%. Next one. With colleagues and classmates, here this is interesting also because schools closed down, so 39% they cannot meet with classmates. Next one. With their neighbors, you see they have a problem with neighbors. They cannot see their neighbors, 30%. Next slide. Sorry, I'm going fast, but I have many slides. If they are treated, this is a nice question. This is racism now, treated differently because of their origin. 17% they say it is worse than before. The next one. If they are treated by others with kindness, it is worse than before, 10%. This next one. If they call them names, 8% because of their origin. And of course, I have to say here that we experience things like this in Greece with newly arriving migrants, because we heard that in Turkey, for example, they had a lot of COVID cases, and when people were arriving, the locals were not so friendly as before, were not really kind, because before there were cases that people received them in a kind way, but not now. Next slide. If they try to avoid them, 16%, this is a big number. For me, others avoid me because they think they have a coronavirus. The next one. Others seems to be anxious about me. They realize that others are anxious about them, 14.5, 55%. The next one. The police, 5%. That's good. At least they don't. The situation is not worse in big numbers. The next one. Now we'll come to the psychological status. Feeling depressed sometimes and all the time. You see the numbers. These are rising. That means that there is an impact of the precautions and the way coronavirus is trying to be controlled. The next one. It is worse than before, 50%. They feel that the depression symptoms are worse than before. Next one. Like they worry too much. You see, sometimes and all the time, 31 and 21 is over 50%, more than half. They feel that they worry too much. Next one. You see, worse, 50.94%. Next one. They are feeling anxious again, 31% and 17, more anxious. So sometimes and all the time it's bigger numbers. Next slide. Feeling lonely. Again, here the numbers are big. Sometimes and all the time, 28 and 17. The next one. Angry, about to explode. 24% sometimes, all the time 7%. Okay, the next one. What makes me worried? My loved ones will get sick. More they worry about their loved ones than themselves, that they will suffer financial consequences. Of course, also 31% that I have difficulty getting the medical care that I need. I will have difficulty feeding my family, 24%. So there are a lot of things to worry about with this situation. The next slide. That future becomes uncertain. I will lose my job, 23%. I become isolated from family and caregivers, 25%. It's in big numbers again. Next slide. Okay, this is, we close with a picture from my island when the boats arrive. These are the people that I'm most interested in, and especially those that they arrive during the last year with the corona virus. The situation was not, as I said before, very friendly, not in all islands. People, when they saw them coming, they were afraid that these people will be infected and they will spread it to the community. Summing up, closing up my presentation, I want to say that again, that this is the first data that came in. You cannot use it as reference. You have to wait a little bit till the report comes out, and I will send it, and you have the link in this webinar, so where you can find the whole report with the 28,000 participants and with correlations and with explanations and with biases and things like that, that now I'm not able to explain. I just wanted to sum up and say that from this first data, we see that there was an impact. I mean, they worry. There is an impact on their psychological status. there is the people, the locals. I'm sure when we isolate asylum seekers and undocumented, we'll see that the response of the locals towards them has changed a lot, not in the numbers I presented here. That's why I say that this data should not be used for references, because they might be misleading, because I'm sure if we divide up the groups, the data will change. Thank you very much. The next slide for listening to, for your attention, for listening to these first presentations. I'm always here for whatever you like to. I don't know, Marianne, I kept the time?
And no, you're perfect. You were perfectly on time.
Thank you.
Thank
Okay.
you. So one of the things I'll let Dr. Kouliarakis do introduce our next presenter. But one of the things that I neglected to mention at the beginning is that we're very excited to have this collaboration with University of West Attica, because 2 years ago we had a course with them on migration and refugee health, and both Dr. Kouliarakis and Dr. Johannidi were faculty in the course, as well as Dr. Guzmano, who you will hear from. And we hope to offer the course again when the next time we are allowed to travel to Greece. But of course, the COVID-19 epidemic has stopped us from doing that for this past year. So at the end of the presentation, we will talk about the course for the students who happen to be on the webinar, so you can learn more about the course that we hope to offer this coming summer. So thank you, George. Sorry.
Okay, thank you very much, Ellie, for the very interesting, although preliminary data you presented. I think that you will find a lot of things interesting when you analyze the data and make correlations. And then it will be more interesting to put the data together or next to the national data that we have in Greece from the general population, to see what exactly differentiates the worries or the feelings of the two groups. Okay, and now I will present Dr. Fouskas. Theodoros is an external colleague of the department. He's a sociologist, and he works with us for the last 2 years doing courses, and we had the opportunity to collaborate in EU-funded projects with migrants. And it will be a great pleasure to invite him to present some indications on the policies regarding migrants and COVID in Greece. Theodoros, the floor is yours.
Thank you, Dr. Kouliarakis. Thank you all for this wonderful event and for the invitation. It's a great pleasure to be here with you. Good morning to all of you in the US. Kalispera to those in Greece. Let me share my screen just to start with my presentation. Let me just give me a minute to share it with you. I think that you now see the PowerPoint. Okay, let me just minimize that, not to block your viewing area. So we will discuss about this particular policy during the COVID-19 times. So I was really inspired from the subtitle of the conference, A Tale of Two Crises. So I will try to start by taking a step back and telling you some things before the COVID-19 crisis in order to set up the framework. First, in this period that we will discuss, it is the unprecedented migrant and refugee flows that we had in the country in 2015, which was coupled with a movement of migratory route leading to Greece from Turkey, which actually tested the mechanism of reception. The crisis that we had was a reception crisis, and the asylum system of Greece was quite stressed and actually overstressed, as we saw in reality. And it also drew the attentions and the attention of the weaknesses and the difficulties of handling that dramatic rise of incoming population who had actual humanitarian needs. During that particular period, despite the difficulties that the country faced, the Greeks showed enormous and unconditional solidarity to those individuals, and this was also organized through state and particularly NGO and international organization support. And then I will move forward to that particular discussion that we will focus on the current situation that focuses mostly on the poor condition in the reception and identification centers, also due to the cases that we have tested and found in those facilities, and also what is the policy that Greece has implemented regarding those 5 specific sectors: border policy, legal status, administrative operations, restriction on movement, and health. So I will start right away mentioning that due to that so-called long summer of migration, hundreds of thousands of people fleeing war zones, mainly from Syria, to actually the Balkan route in order to find safety. And this, of course, gave rise to one of the largest movements of migrants in Europe in the recent period, in recent years. Greece was a main entry point for Europe for almost 1 million of refugees, asylum seekers, and migrants seeking safety. These particular flows actually coupled with that particular pressure on the system. The response back then was that the measures implemented according to the roadmap implemented from the European Commission about the hotspot approach was mentioning that these reception and identification centers in 5 islands of Greece will actually hold and try to filter that particular situation. The national measures, of course, implemented in accordance with European ones, and also in the financial sector as well. This was also part of the reception, identification, asylum services, management of those refugee flows. And many sectors and bodies were involved, including the regions and municipalities, the Hellenic Coast Guard, the Hellenic Police, the hospital, central government, NGOs, international organizations, and even the local communities. So all those actors were also taking action at the same place, at the same time. So the work of all those bodies, including actions and services, the administrative ones, humanitarian ones, from local communities to state agencies, we saw that this particular situation actually was taking place due to that particular flow in the country. That at the same time developed perceptions of and practices towards those individuals. Between 2015 and 2020, we have seen a quite different let's say behavior. This is an actual mural from an island, from Chios actually. An NGO had drawn that in order to show the solidarity and what they did providing support back then. So on the Greek islands, we also had selfless care and support provided by members of society, acts of solidarity, which was marked as quite significant and extensive. This warm reception was also deposited in many ways, and citizens have shown outstanding support to those in need. At the same time, we also had contradictory images due to the limbo that actually those individuals were found and instability regarding the situation. So after 2015, even in the citizens in those 5 islands who had showed solidarity now showed, of course, signs of difficulty to accept this ongoing situation with people in need, in an ongoing actual need. We had in November 2017, we had a general strike on the island of Lesbos, where everybody were chanting that the island is not a prison, not a place for an exile. This, of course, coexists in a situation of that on the one hand the state tries to put pressure also after the implementation of the EU-Turkey statement and to the EU, and at the same time the situation in the islands and on the islands and in the mainland are also under pressure. Although the country has been considered as a place, as a country of transit, even officials after February 6th, after 2016, actually 4 years ago, admitted officially that it is a country of reception. So this brings us actually to the current situation that, as you can see, not only the living conditions, the poor conditions that they face in the reception and identification centers and the accommodation centers on the mainland are quite difficult. And when we are discussing about the pandemic, the COVID-19 pandemic, we see that even the World Health Organization World Health Organization emphasizes that the exposure to those health risks should be taken into consideration due to the conditions that those individuals are found in overcrowded facilities. The conditions without basic health conditions, lacking of necessities. And in Greece, we have an important number of individuals found under these unsafe conditions regarding their health. Camps are severely overcrowded, multiple deficiencies and lack of medical doctors, resulting of course in multiple health issues, deterioration of health, even due to the weather changes, and there's no insulation, there is no heat, there is no safe accommodation in winter, and many feel insecure under these precarious conditions, while many have suffered traumas. At the same time, we see that frequent outbreaks, maybe you have already heard about the fire that destroyed the camp in Lesbos 2 months ago. This was not the first time. We had cases in March 2020, we had in Samos in April 2020. So we had various outbreaks of violence and clashes between the individuals due to their ongoing immobility and uncertainty. Some will try to cook something. There are flammable materials everywhere, so cooking inside the tents, it's quite unsafe. Reasons for outbreak could be also the situation for the poor living conditions, a lack of healthcare, overcrowding situations, and at the same time, they feel they are under psychological breakdown and tensions due to that immobility. The reception and identification centers have been operating, as you can see, inappropriately. Most of them are set up in old facilities as abandoned army camps, factories, and also extending beyond their borders. As you can see, even in the pictures, they extend the tents outside their borders. So the worrying situation here is the reduction in healthcare provision and the situation regarding the squalid living conditions due to the coronavirus pandemic. What we have seen now is that multiple cases have been detected since March 2020. And although we had various, let's say, cases that were in the beginning were in a sense manageable, but at the same time, the first cases of COVID-19 that were identified in the camps actually detected in a period of tension in Greece, while the north borders of the country were under pressure. And this led also to a prevention of entry and border policy actually in the country, a suspension of the asylum applications, and mostly in a way that the country in that particular period was facing actually pressure. So the government and the officials were trying to emphasize on that. This was the period that the first, as you can see in March 31st, 2020, was the first cases that were detected. Since then, actually, we had some cases with very specific, let's say, cases, a very small sample, but later on, after August 8th, these cases actually were increased significantly. And here we can actually, in this particular discussion, focus on the policies that actually the government implemented. First of all, we have restriction on the entry in the country during the first cases due to the situation in the north border of the country, north part of the country. The prevention of entry and the border closure policy was the main, let's say, measures that implemented. At the same time, the local society was also affected from that, and they were not showing any form of acceptance in specific places around the country. However, we see that this was also implemented at the same time in measures, I'm sorry, for the suspension of asylum applications, at the same time the validity of asylum seeker certificates, which was actually extended for a period to cover those particular needs of the individuals. What we also see that particular period is that the ministerial decisions back then were also focusing on the extension of the resident titles of the third country nationals, so to ensure that those who have received legal status can retain it, can keep that particular status. At the same time, another policy measure was changes on the administrative operation. We had particular measures on the suspension of reception and public service of their operation. For example, the asylum service was stopped working and providing service, which was also extended periodically since then. And all administrative actions were suspended, including recordings, interviews, filing of an appeal. Everything was stopped for a specific period, but then checked again for the extension of that particular measure. Also, in the camps, we saw that the movement restriction of movement was implemented with particular common ministerial decision focusing on the measures to not allow anyone to enter only that particular, let's say, situation, and forcing actually a lockdown. They were also implemented measures in order to help those individuals, even than placing ATM machines in order to receive money. They were also established around that particular place where the camp was placed. They were also establishing mobile units in certain cases regarding healthcare. But of course, as you understand, medical evaluation in the perimeter and also in specific samples was not enough. Medical units were also sent, but multiple problems also emerged due to the multiple cases of COVID-19. So what we can see now is that due to that difficulty to take the precautionary measures against the pandemic in the reception and identification centers, and at the same time we see that no physical and social distancing can be kept. So we do understand there is no implementation of hygienic rules, and there's no, let's say, safety regarding that particular issue. And so the ardent decongestion of the overcrowded reception identification centers and accommodation centers required in order to avoid any other rapid spread of the infection, which has been actually transferring the pressure to the state mechanism to transfer the individuals from the reception identification centers and accommodation centers to other centers in order to let's say, relieve certain areas and transfer them. Of course, the ideal thing would be to help them have access to other forms of accommodation, to apartments, hotels, to safeguard at the same time themselves and public health, even alternative modes of accommodation, providing dignity and safety in that particular issue. So Thank you so much for your attention. I tried to keep in time with so many details. Thank you so much for your attention. You can have a look in our publications. Some of them are already published, some are in press. Thank you again for your attention.
Thank you very much, Theodoros. May I remind the participants that they can pose questions through the chat of the Zoom. And now I give the floor to Dr. Passanante to coordinate and present the next two speakers.
Thank you very much. This is the really very interesting presentation and important work. And I look forward to a robust conversation at the end of our presentations. So our next presenter is Dr. Michael Guzmano. He's a professor in the Department of Health Behavior, Society, and Policy in the School of Public Health at Rutgers. He serves as a concentration director of health systems and policy. He's also a research scholar at the Hastings Center and a visiting fellow at the Rockefeller Institute of Government. His research examines the politics and ethics of health and social policy. His research on policy theory explores two questions. First, how should the public be involved in shaping public policy decisions? And second, what are the values embedded in traditional policy analytic techniques like cost-benefit and cost-effectiveness analysis? He's widely published, and in 1995 to 1997, he was a Robert Wood Johnson Scholar in Health Policy Research at Yale University. Dr. Guzmano received his doctorate in political science from the University of Maryland, College Park in 1995. And he's a valued colleague and member of the School of Public Health, and I'm very happy to have him present today.
Thank you, Dr. Passanante. It's wonderful to be here and wonderful to be in this presentation with my colleagues from the University of West Attica. I wish I were in Greece right now, and I'm hoping that we will be able to visit you again soon. I'm going to do my best in a short period of time to kind of give an overview of what I would consider to be the largely ineffective and unfortunately incoherent response to COVID-19 here in the United States, and spend some time discussing the implications for migrants in the US with a particular focus on undocumented immigrants. But I will also spend a bit of time thinking about the policy response and the degree to which we have actually failed to help the safety net healthcare institutions that are serving these migrants. So to begin, it's really important to recognize that while coronavirus and COVID-19 have created some unique challenges and important problems, one of the things that's happened, certainly here in the US, and I think in most parts of the world, is that the pandemic has kind of laid bare some fundamental inequalities in both political, social, and economic problems within the US. This is perhaps most starkly revealed when we look at a combination of geographic and racial disparities associated with COVID-19, with sort of blatant inequalities. So here is just one graph with some data through the end of July, looking at the differences by race and ethnicity within the US. And of course, this isn't surprising when you consider the massive level of health inequality that existed before coronavirus. When we think about social determinants of health, African Americans, Latinx, Native Americans, and other racial and ethnic minorities faced huge problems in housing, in food, and in social stressors that have led to higher levels of chronic illness, for example, which when combined with the pandemic created significant problems. But I would say most importantly, this has also been revealing of our nation's politics, because the level of infection, hospitalization, and death in the US is really a direct reflection, not just of the virus itself, but the political response to the virus. And sadly, this is an image that made its way around social media with Dr. Anthony Fauci from the NIH putting his head in his hand in response to something that the president was saying at one of the briefings from the Coronavirus Task Force. President Trump, as most of you know, has been extraordinarily dismissive of the virus. He was notified and provided fairly extensive information about the virus as early as January 2020 and did not act to mobilize the power of the federal government to start testing, to encourage social distancing and other public health measures, or to produce greater levels of personal protective equipment, for example, for hospital workers and people working in long-term care. Instead, this has largely been a story about the president dismissing the virus as a hoax, something that isn't real, and fake news. And part of the response to that within the US is that rather than having a coherent national response to the virus, this has largely been left to states, which means that we have an extraordinarily uneven set of policies, even to this day, with some states moving toward greater restrictions on movement and requirements for mask wearing, and others, like Florida, for example, being completely opened up. My colleagues and I did an analysis of initial state decisions to issue stay-at-home or shelter-in-place orders early on in the pandemic. And one of the things that you can see here is that the blue states are those represented by Democratic governors, and the red states are those represented by Republican governors. And unfortunately, when we looked at all of the factors that might explain why some states decided to lock down, to issue stay-at-home orders, to close down restaurants and bars, the only factor that seemed to matter was party control of the governorship. It didn't matter how many cases there were. None of the economic factors mattered, or other public health factors mattered. The thing that stood out was what party was the governor. And so we see evidence of a kind of what we call a vertical partisan alignment. The governors in the states were following the lead from national political leaders, and Republican governors were much more likely to be dismissive. There are some important exceptions to this. For example, the state of Ohio has been fairly strong in terms of moving forward with lockdown. But in addition to failing to lock down immediately, many of the same states that were slow to lock down were among the first to open up. And that includes states where the virus was continuing to climb. One of the other things I wanted to do was sort of share with you some of the consequences of this inadequate response. And I'm going to do so drawing on a paper that will come out early next year, looking through the lens of my World Cities project. For the last 20 years, I've tried to understand health systems in different cities around the world by comparing cities that share a great deal in common, but that exist within radically different national health and healthcare systems. So we've started out looking at New York, Paris, and Tokyo, along with London, and we've expanded this to include Moscow and a number of other cities. All of these cities are large global cities with a great deal of population density, which can be a problem, obviously, in the context of a highly infectious respiratory illness. These are also places that are home to many migrants. And so these attract people from all around the world, not only to work in high-tech industries, but obviously attract people to work in sort of the under the stairs economy, working in restaurants, in the food industry, driving taxis, and in some cases seeking care as refugees from war-torn places, as we have seen certainly throughout Greece. And so what we did within the context of our cities is we decided to compare the total death rate, regardless of cause, in the first half of 2020 compared with the average for the years 2018 and 2019. So effectively, we're calculating excess mortality within each of our cities over this time period. We decided to do this in part because we know that countries are testing at very different levels, which means that the rates of hospitalization death, serious illness, may in part just reflect testing regimes and the way health systems are coding or characterizing deaths. In addition, we believe that there may be a number of deaths that take place because people are afraid to interact with the healthcare system due to COVID, and or because the health system is simply overwhelmed by COVID cases, as certainly was the case in New York. And so this is just a brief graph showing monthly levels of death, of excess mortality in each of the 5 cities that we looked at: London, Ile-de-France, which is the Paris metropolitan region, New York City, Moscow, and the Tokyo prefecture. And obviously, New York City just jumps off the page. In April, we had more than 21,000 excess deaths alone. So any suggestions that this is due to coding or the desire of doctors to make more money by suggesting there are more COVID deaths is sort of completely dismissed by a graph like this. As you can see, within our other very dense, very cosmopolitan global cities, all of which have high concentrations of immigrants, the highest level of excess mortality we saw was in London with just under 8,000. Moscow was a little below this, and the peak was a little bit later. Paris was actually in line with London, and Tokyo was quite remarkable with only 950 excess deaths at its peak in April. Ironically, this is also interesting because Japan and Tokyo generally had the least restrictive policies. However, there was a great deal of trust and a culture of complying with public health measures, in part due to experience with other infectious disease breakouts. And so mask wearing and social distancing were not resisted in the same way, certainly not in the same way that we see in New York. Now, in the context of this crisis and this uncontrolled pandemic due to inadequate federal response in the US, migrants are particularly high risk. And this graph, I think, illustrates the multiple reasons why we should be particularly concerned about migrants. First of all, as I will discuss in just a moment, there are serious issues of access to medical care among migrants, particularly among undocumented immigrants, but frankly, even among legal immigrants in the US. Many are either uninsured, have no financial protection, or they are underinsured. They often have limited healthcare options and rely on safety net hospitals and clinics. They have higher level of comorbidity. And these are people who are the so-called essential workers. So in addition to hospital workers and people working in long-term care, we've now come to understand that people who work in grocery stores, in meatpacking plants, in other relatively low-paid jobs are essential to keeping the economy going and to making sure the rest of us are able to live our lives in the midst of this pandemic. And migrants in the US, including undocumented immigrants, disproportionately work in these fields. So if you look at in food service, in construction, they're working here, which means that they are exposed to a great deal of virus on a regular basis. And of course, their social conditions also lend themselves toward a greater risk of infection because they're often living in crowded households, in multi-generational households. And with migrants everywhere, they are less likely to speak the native language. So they're less likely to speak English in the same way that migrants in Greece are unlikely to speak Greek or speak it fluently. And that can lead to obviously communication problems if extra efforts are not made available. There are about 11 million undocumented immigrants living in the United States. And the number, despite the rhetoric from the Trump administration over the past 4 years, has actually been going down for quite a while. They are typically low-wage workers. Most of them are in their mid-30s. They have families, but they work in the farm industry, in the food processing industry, in construction. There was a physician from California who gave a wonderful presentation and said, if you've walked into a building or eaten lettuce in the past week, you have benefited from the labor of an undocumented migrant in the US. A large percent, about 80% of the undocumented immigrants in the US are Latinx, and compared with the US population, they are more likely to be uninsured, they are more likely to have a chronic disease, and they're less likely to receive preventive care for some of the reasons I mentioned before. As a result, they have limited access to health insurance. One thing that's important to note is that, with the exception of um, safety net hospitals, undocumented patients in the U.S. really have very little access to health insurance. There are a few who have access to employer-paid insurance, but that is not the majority, and they are not eligible for any federally funded health care programs. Medicare, which is our program for people 65 and over and those with permanent disabilities; Medicaid, which is the federal state program; or the Child Health Insurance Program for those who are very poor. They've even been excluded from purchasing their own insurance through the ACA marketplaces. So they have to rely on this sort of patchwork system of federally qualified health centers and safety net hospitals. And that brings up the last point I wanted to talk about, which is, how well has the federal government responded to the pressures that have been placed on the safety net system? One thing that the government did in response to the coronavirus was to pass in late March, with bipartisan support, the Coronavirus Aid, Relief, and Economic Security Act. The CARES Act is most well known for providing extra unemployment benefits to individuals in the United States. Those have now run out, and the Congress is currently fighting over whether to extend those benefits. But the other thing that the CARES Act did was to provide extra payments to hospitals that had been particularly hard hit by the coronavirus. Interestingly, however, under the formula that was developed by the Department of Health and Human Services, they did not primarily focus on hospitals that were receiving a disproportionate share of COVID patients. This would have shifted money primarily to safety net hospitals providing care to the Black and brown communities that have been disproportionately affected by the disease, and it would have provided a lot more care, or a lot more money, to hospitals but I'm having trouble getting it to move. Here we go. These are the payments that came from the CARES Act to hospitals. And we looked at the days of cash on hand, which is a measure of a hospital's financial health. And interestingly, a disproportionate share of the money from the federal government, rather than going to hospitals that provide care to poor communities, to vulnerable communities, including the undocumented, most of the money actually went to hospitals that were fairly well off before the coronavirus hit, in part because they lost a lot of money. And so the revenue they lost was accounted for by money going to the federal government, which means that we've actually increased the kind of inequalities that we see within the hospital system. And with that, I'm going to end, and thank you very much for listening to me.
Perfect. Thank you. Thank you very much, Dr. Guzmano. All right. And our final presenter is here. And let's see, there he is. Very good. Dr. Perry Halkitis, the Dean of the Rutgers School of Public Health, and the person who's really responsible for encouraging us to create this Office of Global Programs and to have our collaborations around the world, and particularly in Greece. Dr. Halkitis is a public health psychologist, researcher, educator, and advocate who is our Dean and Professor of Biostatistics and Urban Global Public Health at the School of Public Health at Rutgers. He's the founder and director of the Center for Health Identity, Behavior, and Prevention Studies. For 3 decades, Dr. Halkitis' program of research has examined the intersection of HIV, HPV, and other STIs with drug abuse and mental health burden. This research program seeks to determine the biological, behavioral, psychosocial, and structural factors that predispose these and other health disparities in the LGBTQ population, and in turn to translate this knowledge through the development of tailored and adaptive interventions in order to reduce disparities. CHIPS also is a training site for the next generation of scholars who seek to improve the health of LGBTQ people and populations. His research program has been awarded over $30 million in grant funding. He's co-authored 4 books, over 250 peer-reviewed academic manuscripts, hundreds of papers for professional conferences, and dozens of keynotes. Dr. Halkitis has been the editor-in-chief of Behavioral Medicine since 2013 and is the founding editor-in-chief of the Annals of LGBTQ Public and Population Health, which published its first issue in 2020. And today he'll be speaking on COVID-19 in the US and Greece.
Oh, great. Hold on, let's see. Let me unmute myself. Can you hear me, everyone?
Unmuted. You're unmuted.
I'm unmuted. Well, great. I'm sorry. It's been a whirlwind morning here in Newark, New Jersey. But kalispera, hello to my friends in Greece, hello to my colleagues at Rutgers. I will try to bring us home today with just some comments about the COVID-19 pandemic here in the US and in Greece. And, you know, I've joked over the course of, maybe joke is the right word, over the course of the last few months that, you know, when I'm retired, which hopefully won't be that far away from now, I will think of my life and my career as a public health person being defined in so many ways by fighting 2 viruses, HIV and now COVID-19. And I think the lessons we've learned over the last 40 years are a roadmap for all of us as we're moving forward. So let me just try to summarize everything and leave you with some final thoughts as we continue to fight this disease in our world. So as you all know, COVID-19 is a disease caused by the SARS-CoV-2 virus. It can be spread from person to person. It spreads very rapidly. For somebody like myself who studied HIV for his whole life, this disease is similar but incredibly different from HIV. So for example, in the United States, there have been 700,000 people who have died of HIV in the course of the last 40 years, but in 10 months, close to 250,000 people have died of COVID-19 in the United States. HIV is incredibly challenging to transmit. SARS-CoV-2 seems to be much more easy to transmit. And so while we have some lessons from the past, these viruses are not at all the same. As you know, there is a variety of symptoms that are associated with COVID-19. They're listed here. Not everyone who has the infection has these symptoms, and therefore are challenged. Our challenge that 40 to 50% of the population that is infected with the virus shows no symptoms and continues to engage within the community, within their population, spreading the disease. For those of us who've been doing public health work, and those of you who have been doing public health work, we know that at the beginning of the 1900s, we had the 1918 pandemic. And since that time, death from infectious diseases has really decreased. However, there is a new pattern emerging with HIV and COVID-19 and Ebola and H1N1 in this increasingly global world. It seems likely that this pandemic is just the latest in a series of pandemics we're going to face. So here's where we are today. When we look at this Mercator projection of the world, which has the United States oversized, but you know, what can you say, and Europe, but this is the Euro version of the world. What you see is that in the United States, there is extremely high risk, as there are in certain parts of Europe. And I will get to the numbers more specifically in a second. Here are some numbers comparing 3 countries in the Americas, Brazil, Canada, and the United States, each with different populations, each with different numbers of deaths. But to date, you can see that there are radical differences. For example, in the United States, we've had over 10 million cases. In bordering Canada, we've had only 266,000 cases. Similar patterns when we look at Greece, Italy, and Sweden in the European context. Again, different populations, so I'll control for that in a second. But and different case numbers with, highs of close to 1 million in Italy and lows of close to 58,000 in Greece. Deaths of lows of 825 in Greece, but highs of 41,000 in Italy. Again, very neighboring countries. And so when we look at this, when we control for the population and we look at on the left-hand side, which is cases, and on the right-hand side, deaths, what we see controlling for the population is that Greece, unlike the United States, looks pretty good. 559,000 cases per 100,000 in Greece as compared to over 3,000 in the US. 64 deaths per 100,000 in the US, only 8 per 100,000 in Greece. The only country that surpasses Greece is Brazil, another country with another autocrat in charge of it. And when we look at the total number of cases, this is where I can't disagree with the person who's running my country right now. We have done a lot of testing, but we also have a lot of population. And so it doesn't matter that we're doing more testing. The fact of the matter is that people are getting sick and they're dying. And this is the mortality rate. When we look at the positivity rate and the mortality rate, once again, what you see relatively here is that Greece is doing relatively well as compared to neighboring Italy. And certainly as Sweden, which thought it would use a herd immunity approach to managing the disease. Here's a map of the United States and where we are right now. And at the beginning of the epidemic, most of you know that the epidemic was focused on the coast, for that blip in New York and New Jersey, and on the West Coast, in Oregon and in Washington. And what you see right now is in the middle part of the state, of the country, in rural areas, there's a high intensity of disease. And this also manifests when you look at it state by state. Interestingly, for those who've been watching the election returns, the election is over, my fellow Greeks, despite what that person in the White House says. The country seems to map on with red and yellow in this very similar way that it seems to map on with red and blue. And so I have been spending a lot of the last few years writing about how politics shape public health and how we as public health researchers and as public health advocates cannot stay silent in these moments, and that making political statements is as much as our responsibility as is doing good science. And again, if here is just a breakdown in our country, if you look on the left-hand side, South Dakota, which is a state, believe it or not, where like, I don't know, maybe 100 people live. No, actually more than 100 people. But South Dakota, which is an extremely conservative state, large number of cases. The governor doesn't believe in masks. People are on their deathbed in South Dakota saying they still don't believe that COVID-19 is real. And so we have this condition where politics really shape public health. So over the course of the last 9 months, I've been talking really in the absence of a vaccine about the need to target, test, treat, and trace. And this 4T model has been really rooted in the idea that not every population is at equal risk for COVID-19. And so we have to be very smart in how we think about how we target our testing, how we do our treating, and how we do our tracing. And I think targeting is going to be really important also as we roll out the vaccine. There's some indication that the vaccine is going to go to those most vulnerable, the elderly living in communal living spaces. My argument is that's fine. It should also go to 18 to 30-year-olds who are the ones who are really spreading the disease in our populations. But if in the absence of a vaccine, this is the model that we have and the model that we have built at the Rutgers School of Public Health. As you all know, there's various kinds of tests. There's the PCR test, which tests for presence of the virus, and it can be done either through a nasal swab or through saliva. There's the antigen test, which is a rapid test, which also tests for the evidence for the virus, but is much less accurate, only 70% accurate. And there's an antibody test that doesn't indicate active infection, but indicates previous infection. Unfortunately, most people seem to clear their antibodies. It's not really clear what role antibodies play in maintaining the disease. I am glad to report that 9 months into this epidemic, I still have my antibodies. So I will take them for whatever they're worth. But we have a variety of different tests that are available, including the saliva test, which I actually did the other day, which comes to your home, you spit in a vial, you send it back, and the results are sent to you via email. Very, very efficient, doesn't require that we leave the house. The other piece of the puzzle is this contact tracing piece, which is when you identify people who are positive, you then try to contact those that they have exposed. And contact tracing seems like a really great idea, and it is a really great idea, except it's really difficult to do when the cases are exponentially growing. And so Contact tracing is supposed to prevent exponential growth of the disease, not ameliorate it. Unfortunately, we have not used it wisely in our country, and as a result, the disease continues to spread. So while we will make continued efforts to continue to contact trace, I think that boat has sailed. And, you missed the opportunity to really contain the disease with this particular strategy, although we will continue to use it. The New Jersey model for contact tracing and testing was built by an association of government with the Department of Health and Higher Education. So New Jersey, the New Jersey Department of Health funded our school, and folks like Marian Passanante and others were able to develop a curriculum that actually trained contact tracers and continues to train contact tracers throughout the state. This 18-hour module that consists of these components, with a lot of it really being focused on cultural humility, communication skills, and interviewing skills, because one of the biggest challenges with contact tracing is actually getting people to trust you and to disclose information. We knew that we faced that when I was doing HIV work, when people did not want to disclose. We face it now for very different reasons. In the HIV time, it was really focused about stigma. I think right now it's mostly a political statement and fear that one's identity and fear of one's privacy being interrupted. So over the last few months, we've spent time thinking about how we reopen businesses, and there's a variety of different strategies that have been used, including staggering employees and monitoring health. Unfortunately, my friends, despite our efforts to open things and open safely, it's not worked so well. And I'm going to share some recent events with you here. Just the other day, this op-ed was published that I wrote called "Hope for the Health of People and Populations in a Biden-Harris Administration, Lessons the US Can Learn from my Loss." And I actually do think the Americans can learn a lot from the Greeks. And I just don't say that as a Greek American and a child of Greeks, or somebody who's very proud to be Greek, but because Greece really actually has done a model job in containing the virus. Maybe not so much today when I show you a slide, but overall it has done it. This is available in the Hellenic News of America if you're interested in it. The reason I make that last comment is because today we learned that Mitsotakis, your amazing prime minister, who I think I like, and I think has done a really good job in maintaining this disease, has refused to go into quarantine after being potentially infected by the Archbishop. So here's the problem. As we know in the United States, do as I say, not as I do. When you have a leader who is saying you need to wear a mask and distance and doesn't do it themselves, well, that message doesn't really resonate. It's sort of like a parent saying to a child, don't smoke while the parent smokes. So I think you have a dilemma on your hands with this one, my friends in Greece, and I think something that is politically not a good idea for the prime minister, despite whatever the rationales are for him not quarantining. Still, Greece has been a success story. It has had a unified approach. It started canceling events in late February before a single death was recorded. There was systematic closures of first schools, then cafes, then full lockdown, and then developed a really effective program to sustain tourism, as you all know, the EVA program. I think this is, in fact, rooted in the Greek culture, one of respect for science and respect for public health, a familial orientation, and altruism, which I think are characteristics that are seriously lacking in my country, the United States. I'm trying to have Greece be my country too. I'm very close to getting my citizenship, so I may just like come there and be there with you full time. The Greek approach to COVID-19 has been one that's based on trusting experts, on speed, on transparency and clear communication, on strengthening the public health system, using a whole society approach, recognizing that public health must work with government and industry. It's very much a model that Leslie Cantor and she's one of my colleagues, have developed for urban public health here in the city of Newark, and by defying cultural norms, right? And so what we've not done so good job here in the United States is defying cultural norms. I still don't understand for the life of me why we're playing football. Why? Why do we need football? And yet we do it because somehow we think it's our God-given right. Why do we think it's appropriate for us to next Thursday get together with our families, Thanksgiving, when we're in the middle of a crisis? It's wrong. And so what I've been saying during interviews and what I've been saying, to the press is our grandparents lived through World War II and the Holocaust. We lived through 9/11. We've lived through the pandemic of 1918. Our great-grandparents, we can sacrifice also just a little bit for the good of society. And I think Greeks do that better than Americans, just because of our culture and how we think about each other. Let me just sort of wrap up here. You will see that despite the fact that the Greek, can I have a drink of my coffee first? Because I am a Greek after all. Delicious. Besides the fact that Greece has done, despite the fact that Greece has done a really good job, I think, your numbers are also increasing like our numbers. But what is really telling from these two graphs is that your numbers stayed flat and you have a little spike now, perhaps because of the tourism, but ours just shows this like inconsistent pattern of like, stay safe, we're safe, and then we're not safe, we're safe, and then we're not safe, we're safe, and then we're not safe. And so inconsistently, we continue to see these ups and downs in the disease in our country. In my state of New Jersey, it's very problematic. I'm actually in Newark right now. These are numbers from last week. The numbers are actually worse this week. The transmission rate of 1.25 means that the disease is spreading very, very wildly. And when we look at New Jersey, all of the indicators to me are the most important being people being on ventilators and people being in hospitals are going in the wrong direction. It is one thing to say that cases go up, but when hospitalizations go up, that's when our problem occurs. And our healthcare force is being bombarded once again by a disease that can be prevented, and they are being pushed to the max. I did an interview the other day when somebody asked me about why healthcare workers were burning out. And I remember, and I said to her, this is very similar to what happened with AIDS. People were dying left and right, and healthcare providers were getting very burned out after seeing all the death around them. I fear what's happening to our healthcare providers now, because we have the possibility to prevent this disease, but we're not doing it, and we're making their lives much more difficult. So on November 12th, the governor of New Jersey made some decisions about effectively closing things. So no dining between 10 and 5. Not really sure what's so special about 10 and 5, but okay. Casinos must stop serving. They've been a variety of things. So these are small steps. I don't think they're actually radical enough. I actually believe in the Greek model of lockdown, and I actually believe in the model that my mayor just said, which is Newark is going to lock down for 10 days, starting the day before Thanksgiving. I think you can't do it halfway. It's sort of like, you can't just sort of say, well, you can have 10 people in your house. And my response to that is, well, it's fine if it's 10 people who are in your family who are all tested and negative. It's different if it's 10 random strangers. So the Newark mayor is actually doing his own approach and is actually ordering a 10-day lockdown because the disease is extremely out of control in New Jersey. So what the future holds, I think, what we're seeing right now, continued deaths. We have preliminary approvals of the vaccines from Pfizer and Moderna. They will probably roll out over the first quarter or second quarter of the year. We will continue to have widespread closures, as we're beginning to see right now. New York City became a totally remote teaching Board of Education schools starting 2 days ago. We're starting to get a better understanding of this disease. It's not just about the immediate, but there are actually long-term repercussions of the disease. And we need to finally start establishing some new norms about large group gatherings. I think that thinking that we're going to go back to the way things were before is really short-sighted. I think the lesson we also take away from this is the need to increase funding for public health and prevention. The public health efforts have been bone dry for the last several years in the United States, and hopefully this is an initiative to begin again. I want to just leave you also with this chart that shows that if you are reopening, we can't just reopen one and all, that there are different areas that will create different risks. And as a result of that, we have to be thoughtful about how we continue to reopen. So I went through that very quickly, but I just want to summarize here for you and just sort of say thank you for your collaboration, especially to my colleagues in Greece, my colleagues here at Rutgers also. We hope that we will be able to see you relatively soon in person, I don't really mind wearing this jacket, shirt, and tie with my sweatpants on because my legs are very comfortable right now, but I wouldn't mind wearing a suit and actually being in person, meeting you. So hopefully next summer, we will be able to see each other in person. I appreciate everything you do. Please stay healthy. For those of you who are celebrating Thanksgiving, happy Thanksgiving, Kala Christouyena, and I will see you all very soon.
Thank you very much. So at this point, I'm going to ask all of the presenters to please put their cameras on because we are going to move to our question and answer period. And Dr. Kouliarakis will be moderating the questions and answers. As he mentioned, he's an associate professor in health psychology at the Department of Public Health Policy at the University of West Attica in Greece. He has more than 25 years of teaching experience on a postgraduate level, research experience, and leading and implementing public health-oriented programs, mostly funded by the EU, and active participation in national and international conferences. His research interests are focused on studying, understanding, and interpreting psychological determinants of health and illness behaviors, health literacy, and behavioral economics. Thank you, George.
Thank you, Marianne. Again, I'll ask people to unmute their microphone and proceed to a question to any of the speakers. I have, there is one comment from a colleague, Dimitris Papamichail, saying briefly that putting restrictions in camps there is not, it doesn't seem to be efficient, and it doesn't goes in line with the ECDC relevant guidelines. I don't know if Dimitris would like to make a comment on that also, or say a question or whatever.
Thank you, Dr. Kouliarakis, for mentioning my comment. Just wanted to add this to the conversation, not to say anything in addition to that. My point is that all the restrictions were against ECDC's guidelines, and I think that maybe was a problem because when we really had cases in the camp, and maybe we had to take some measures, then all those people living there were very angry about all the restrictions that were preceded. And we saw all these fires in Moria camp that probably was an answer to this restrictions made without any evidence-based. Just this. Thank you for mentioning the comment.
Okay, there is, before I ask Eli and Theodoros to comment, I may add a question from Min Kim, saying how what was the organizational intervention through the pandemic and the role of humanitarian organizations, how if they have the resources to help migrants. Either Eli or Theodoros may comment on that.
Okay, I can say something. You mean this? I understand the organizations that support migrants, right? If they have.
Yes.
Okay. Well, we had a strange situation after some time in Moria when there was the riot of migrants. A lot of NGOs were expelled from the island. And of course, the reasoning was that these people were working against the Greek government and the rules that they tried to put on camps, and in favor of smugglers who were bringing migrants to the islands. So now the organizations operating on the islands that, and of course in other, are very few, but of course they do support in any way they can. The problem is that when they close the camps, they let everybody out. I mean, like I know from Vial in Chios, when there was a lockdown, they said nobody in. They didn't let anybody, not from the NGOs, from any other organization to enter. So in this question, there is not a definite answer. Yes, they do. Yes, they have the means, they can help, but sometimes depends on what are the rules by the government. For example, if we have a very strict lockdown, nobody can go near, of course. They don't let people without food, for example, or basic, they cover their basic needs, but that's all. I don't know if I covered the
Yes.
Theodore,
Yeah, and just to add something, I completely agree. Just to mention something about Dr. Mikhail's comment with which I completely agree. Just to build on something on that, we also had similar outbreaks of violence, fires, and let's say that those individuals were not able to stay there anymore. And so this was an ongoing situation, because we had also a fire in Lesbos again in March 2020, and then in another island, like Samos, a month later. So this was also something that was building as a distressful, let's say, environment. Regarding the question of that had to do with your organizations, a humanitarian organization, I can give you an example, a specific example with an international organization that provides also humanitarian help, especially for children. UNICEF, for example, in Greece, let's say, adapted their work to the current situation. They provided, let's say, as I remember exactly, 11 languages, information how children can use the synchronous and asynchronous system of e-learning that the Ministry of Education in Greece provides. And at the same time, they provided material, and this is how they try to support. So to adapt, they also gave, also translated information with posters and leaflets, and tried to inform those individuals in the camp about the measures and how they can protect themselves, which is the proper use of the mask, all those details translated in 11 languages and distributed in all camps around Greece.
And
Thank
if
you
I
very
could,
much.
George, if I could just make a quick comment about the situation in the
Please.
U.S., which is
Yes.
parallel, and this preceded COVID-19, but has continued. As many of you know, we have a situation where there are detention centers at the U.S.-Mexico border with many people who are locked up. And we have similar concerns. And again, this preceded any further lockdown with regard to the pandemic, about NGOs being able to get in and make sure that the human rights of people who are being detained are attended to by the U.S. government. And so this actually goes back, I think, to the original comment from Demetrius about locking down the camps and having an evidence-based approach. Because while we see huge differences between the U.S. and Greece, not only with regard to COVID, but with regard to approach to migrants, I think one of the things that we see in many countries, particularly with regard to migrant health, is an effort to drum up fear about migrants. And one of the oldest stories about migrants is that they can be a source of infection and infectious diseases. And so advocates for migrant groups are frequently trying to guard against that kind of stereotyping that goes on. And I think that is part of what we are seeing with the policy response to COVID-19, both in Greece and the US.
Thank you, Michael. Is there any of the colleagues who attend to question to any of the speakers?
May I
Yes?
say a couple of words?
Oh, our dean.
Hello,
Good
this is
Professor
Elvira
Pavi.
Pavi. Firstly, I want to congratulate all the speakers. I mean, it's been very interesting to hear all these presentations, and it's a very important food for thought. We do know that at the end of the day, it is politics that shape public health, and health and social inequalities is a deeply political issue. But to me, it was very interesting to see this graph that political party affiliation of the governor was the most important, or the single factor which was associated with the policies for COVID. We see in Greece here that there is a fatigue in keeping the measures. And I was just wondering what is your opinion, because there is a fatigue of the people. because it takes so long. You know, during the first lockdown, we kept everything, and we had the feeling that, okay, it's a very strict lockdown. It will last 1 or 2 months, and then everything will be solved. Now, there is this psychological burden that there is no light at the end of the tunnel. So there is this fatigue. And we also see that political party affiliation relates to mask denial. And also we have seen the church not being very willing to stop the masses and regarding Holy Communion. So to me, it is a big issue is how you pass the message. And in Greece, there has been an emphasis on national campaign, but there hasn't been a lot of work being done in the community. These are my thoughts that I would like to share with you.
Yes. Michael, do you want to make a comment on health inequalities and the?
Sure. Well, first of all, thank you, Dr. Pavi, as always, very insightful comments, and I agree with you completely. I think one of the things that you're seeing in the U.S., for example, is you're seeing a similar kind of fatigue to the fatigue that you're describing in Greece. Unfortunately, we don't really have a good excuse for the fatigue because we never really locked down in the same way that Greece did. It's one of the things that people have been writing about continually, and Dr. Hilkidis alluded to this, for example, is we're now talking about shutting down schools. You think about churches and religious attendance, that people are sort of extraordinarily important to people, sort of spiritually, but we're keeping bars open. Right, the state of New Jersey, which is trying to follow numbers, as he suggested, has limited indoor dining between the hours of 10 p.m. and 5 a.m. I guess that's good. That's probably when people have had too much to drink and maybe ignore social distancing even to a greater extent, but that's hardly a lockdown. And so we are keeping bars and restaurants open in part because our economic policies have not allowed those businesses to stay viable. So they're understandably fearful of closing, of the economic disruption, but as a result, we're spreading the virus in a way that's out of control. But again, with all of this, and I wasn't at all surprised to see the findings, unfortunately, by party affiliation and the governors, because what we are seeing throughout the pandemic is an exaggeration of the underlying political and economic and social divisions that existed before the virus showed up. It's just shining a spotlight and in many ways elevating these differences in painful and powerful ways.
George, I want to make a comment.
Yeah.
Can you hear? Yes. Okay, thank you, Mrs. Pavi, nice to see you. Thank you for your comment. You give me the opportunity to say, like Mr. Halkitis, I always compare COVID with AIDS, because I used to be responsible at the time we were in the National School of Public Health for the AIDS campaign. And what I want to say is that at that time, every time something was going wrong, we could not persuade the people. We were blaming ourselves. I remember in a European meeting, we were trying to see what went wrong, and we couldn't persuade the young people to wear condoms at that time. Now, what I see is that they try to blame people for conspiracy, I agree with this fatigue. People are tired. You know why? In my opinion, is that they don't try to make a campaign. They just try to put a label. The people are in a conspiracy, in theories. They are, in Greece, we use the word psekasmeni, meaning kind of like crazy people who don't know what they are talking about. And what they don't do is to see what went wrong And the people stop it. I don't believe that people don't believe in the COVID. They believe in it, but they are just tired. Why? Because of the mass media. Watch out what happens. I don't know what happens in the US, but in our television, if you open it for 1 hour, you think that you go straight to the grave. All the time, people in ventilators, death numbers in hospitals. I don't know how they allow journalists to go into hospitals and take these sorts of people in hospitals dying at the last moment. So I think that something is wrong with the campaign, and I don't see any criticism from those responsible for the campaigns. What went wrong, and we missed these large numbers of people who go out around the world and they break things and they make this fuss. I think we should try and see why we don't pay attention. And I ask psychologists always to tell me the mechanisms. George, you could tell me when something is pressuring you, when I have so much fear, lack of my liberties, I cannot go out, like freedom. Every time I open the TV, I say, I want to make a story to feel better. What is the story? COVID doesn't exist, I don't know what, but I need to do it. It is the way they are approaching us, in my opinion. Okay, I stop here.
Yeah, there are, of course, there are psychological mechanisms explaining the behavior, but I think it's not time to go in deep with this. I take a comment from Dr. Halkitis, who said that in Greece we trust science and we enforce public health. From a policy point of view, the criticism that this government takes is that it was relied too much to the medical science, and left outside all the behavioral issue and behavioral sciences. And of course, the system we see here in Greece, the problems we had in the Greek health system, which was very hospital-oriented, and there was no orientation to public health and primary health care. That's I think that from a policy point of view, this is a criticism and a bad condition for having this spread again.
Yeah, please.
Yes?
I just want to add something on what Michael and Ellie just mentioned. And I think Michael will completely agree. I want to build on that contradictory policy based on the economy. Last summer in Greece, although we had that first phase of coronavirus measures, then the Greek state decided on the one hand to promote tourism quite aggressively, as everybody was mentioning, with slogans like such as "We stay safe and enjoy Greece" and endless Greek summer, emphasizing that Greece is the most COVID-19 safe Mediterranean country. And at the very same time, we were seeing measures gradually imposing, new measures being imposed to the general population, especially on migrants. And at the same time, we were open to for tourism, but the camps and the facilities were locked down, actually.
Okay. Is there anyone who had a comment, or I see Mr. Rigas write some comments regarding the role of mass media and the policy that China has built the new hospitals. Okay, I'm not sure if Mr. Rigas would like to make an oral intervention, because it's not clear what's his point with the comments.
Although if I could say one thing in response or in contrast with the United States in terms of the hospital system, because I agree with that, we really should be investing more in basic public health that would alleviate the problem of needing more ICUs, more ventilators, more hospital beds. But it is somewhat ironic in the United States and a reflection of the fact that we have primarily a for-profit and a market-driven hospital system and a healthcare system generally, that in the midst of a global pandemic, we actually have a number of hospitals that have closed and a number of other health facilities that have closed because they, for a temporary period of time, had to stop doing elective procedures, which turned out to generate lots of their revenue. That in part explains those hospital graphs I was sharing before. It's not that you don't have hospital closures in Europe or the rest of the world, but you're far less likely in the midst of a pandemic to actually reduce your capacity. Having said that, there's certainly a tremendous variation in response to whether or not you can quickly increase your capacity. And having spent some time in mainland China, I'm not at all surprised that they were able to build hospitals overnight, because if you sleep for 2 days in Beijing, you wake up, there's another building next door to your hotel. So that's a fairly familiar situation in China.
Okay.
All right.
Can we go now to the discussion regarding the course?
Yes, please. Thank you very much.
Yes.
Thank you all for the comments and for the really interesting discussion. Oh, Hema, can you put the slides up for the course? So I'm just going to briefly describe the course that was offered in Greece 2 summers ago, and we hope to offer again in summer 2021. This is, next slide. So the course was offered with faculty and students from both Rutgers School of Public Health and the National School of Public Health at the time, now University of West Attica. It was on migration and health, and the idea was to cover a broad spectrum of issues related to migrants' health and related to policies in the European context. We offer the course in the summer. It's a 2-week course. We're hoping to offer it again this summer, travel restrictions pending, June or July of 2021. And we hold the course in Athens at the University of West Attica. It will be held for the first week. And then in the second week, last time we offered the course, we went to the island of Chios. The question now is which Greek island will we go to? The students had a wonderful experience last time the course was offered. They worked with Doctors Without Borders. They were involved in an immunization campaign. And I can tell you that our students think it was a life-changing experience for them. Next slide. So the way we offer this course is the course was developed jointly with the faculty from Rutgers and the faculty from University of West Attica. We will enroll 18 students, up to 18 students from Rutgers and up to 16 students from Rutgers and 16 students from University of West Attica. It will be taught jointly by faculty from both institutions. So Dr. Guzmano was our lead teacher from Rutgers last time, and I'm hoping he will go, I'm sure he will be happy to come back and continue to teach the course. The people on the panel will all be part of this course as well. It involves both classroom learning and field learning, as well as cultural activities. We make sure there's lots of time for cultural activities in addition to all of the learning that the students experience. There is some prior work and some work after attending the summer session, but I think most students from both locations were very happy to be able to do this, and they earned Rutgers credit for the graduate level course. And the course grades are based on reflections, some group work, and we'd like to have more group work because we like to have the students from University of West Attica and Rutgers work together on projects. And then there's a final paper as well as class participation. Is there anything, do I have another slide? Yeah, okay, so these are the course objectives. By the completion of the course, the student should be able to analyze the role of social, economic, and political factors that influence migration. So we've been talking about those factors a lot today. Understand the characteristics of migrants and refugees in the European context. be aware and able to identify cultural diversity in the field of health, describe the diversity of public health challenges when dealing with migrants' health, realize the multiplicity of migrants' health-related issues, and formulate strategies for improving refugee health. I can tell you that our students have continued to be in touch with the faculty in Greece. They continue to do work to try to get donations and to send things to the migrants on the island of Chios. So I not only, as I said, the students say it's life-changing, but it's also something they've continued to maintain a strong passion about. So I want to thank everyone who did the presentations today. I think they were really excellent. Thank Ohema for all of her organizational skills to make sure that this all worked very well. And thank you to all the participants, both from Greece and from the United States. George, do you want to make some closing comments?
I'd like to add that the experience of 2019 in Athens and in Chios was also very inspiring for us as teachers, let's say, and our Greek students. It was the first time that the National School of Public Health was involved in such international collaboration in the form of the course. And we had the opportunity to exchange opinions and experiences, the two groups of students. And of course, we had a very good time in summer in Chios. The students enjoyed the summer there, and we hope that we'll again have the opportunity to have the students from the US again in Greece.
So thank you very much. And I appreciate everyone's time and look forward to working with you more in the future.
Thank you very much. Thank you, everybody. Thank you, Hema, for the support. Thank you,
Yes,
everybody.
thank you.
Thank you for everything. Thank you. It was a
Thank
pleasure.
you. Thanks for being here.